So this is our evidence-based practice group presentation by myself, Shelby Dixon.
I'm Rhonda Hood.
I'm Maria Peters.
And I'm Savannah Jones.
We're in group Garden Supri 4. So we are doing a presentation on something called Sweeties, also known as 24% oral sucrose. You may have seen these in the clinical setting, especially since you just finished your OB rotations. I was at work one day assisting a nurse with an IV insertion. As she handed this to the parent, she said, "This should help relieve some of your baby's pain." The nurse kind of looked at her, or the mother looked at the nurse like, "What do you mean this should relieve my baby's pain?" I think it would have been very beneficial for the nurse to have said, "This will relieve your baby's pain by however it is found that it relieves pain." I don't ever want to be that nurse, so we completed a research project to understand how it works, and continuing on with assisting the nurses. Oftentimes, some nurses will hand the parents 1 or 2 packets of Sweeties, others will hand the mothers 5 or 6 packets of Sweeties. So I began to wonder, how much is too much? Can you give too much? And is there a guideline for how much you should be giving? So how would this affect you as a nurse? As far as scope of practice, any healthcare professional working in a NICU, nursery, labor and delivery, postpartum, or a pediatric, acute, or even primary care setting may come into contact with Sweeties or oral sucrose. If you don't choose to work in these departments, you might see this in an emergency department, intensive care unit, or surgery. If none of these interest you, you might run into this as a parent. So why is this important? It's important to determine how oral sucrose works to relieve pain, because I, as a nurse, want to be able to tell the parent, this is going to relieve your baby's pain, and inform her how. We also need to develop a protocol correctly to administer oral sucrose to infants. Although I'm not a pro researcher, I did look to find a guideline or a protocol and was unable to locate one that specified the increments in which oral sucrose should be given and the exact amount. It's also important to educate the patient's family so they understand that their baby's pain is well controlled throughout the procedure. It is also important that we evaluate the long-term effects of repeated oral sucrose, and we'll touch on that later in our presentation. So our PICO question was, in hospitalized infants experiencing pain, does 24% oral sucrose solution compared to other comfort measures reduce the pain response during a painful procedure? This is our literature table. Each of us are going to speak to how we did our searches, and then we'll follow with our findings table. My searches are listed first. I completed search 1 through 3. I used CINAHL for the first 2 and Science Direct for the third one. I basically used the same limits each time, looking for an article written in English, available in full text, nurse as any author, peer-reviewed, and after 2011 to make sure that it was relevant. The first search I completed was sucrose analgesia, because that was specifically what we were looking for. Unfortunately, we only received 2 articles. We decided that both of those were relevant, and we did use those, but realized we needed to broaden our search. So then we looked for simply sucrose. We were returned with 18 articles, and the ones we selected were based specifically on oral sucrose given for pain management. The third one, we decided to use the Boolean phrase, and, so that we made sure that we linked sucrose analgesia to adulthood to see the long-term effects. The article selected out of the 15 was the only article that directly connected the 2.
My articles were 4 and 5 listed here. Both were taken from CINAHL because I wanted it to be nursing specific. The first criteria I searched for was sucrose for pain relief in infants. On both my article selections, I limited the publication to 2011 and present, so it was current literature that I was looking at. The first results from CINAHL produced for sucrose for pain relief in infants, only 2 articles. However, they were 2 very good articles. The first being the use of oral sucrose for procedural pain relief in infants. This is a randomized controlled trial, and I am going to do an appraisal later on in our presentation of this particular article. The second, I searched for neonates and sucrose. I got back 28 total articles and found a good one titled Promoting the Use of Sucrose as Anesthesia for Procedural Pain Management in Neonates. This was a review of current literature and another good quality article.
My articles were found in row 2 from CINAHL when we searched for sucrose with the limitations Shelby already mentioned. Out of the 18 articles, I chose these 2 articles because the first one oral sucrose as analgesia for neonates, how effective and safe is the sweet solution. It was a case report, and it was a credible study. The second one, hospitalized infants who hurt a sweet solution with oral sucrose. That was a randomized control study, and we found it very resourceful in showing how sucrose is effective.
The literature search that I conducted is number 6 and number 7. And I looked in PsycInfo because while we were really concentrating on the physiological effects of sucrose as part of our study, I also wanted to know if there were any behavioral effects. So I thought that that would be a good database. Again, my limits were similar. I limited the publications from 2011 forward. They needed to be peer reviewed, and I wanted a linked full text. And the search returned 236 articles. Most of them were eliminated because they did not have a nurse as one of the primary authors. From that search, I did pull one, which was a very good study, the effects of combined use of non-nutritive sucking, facilitated tucking, and oral sucrose. So it kind of combines some other non-pharmacological measures in with their research. And then, of course, I did search CINAHL with the phrases non-pharmacological pain management in infants. Again, nurse's primary author since 2011, peer-reviewed journal. And that search produced 38 articles, and the article that I chose was effectiveness of oral sucrose for pain management in infants during immunizations, because I thought it would lend itself to our research in looking at infant age that was 2 to 6 months of age.
So this is our first article from the findings table. This article was titled Oral Sucrose as Analgesia for Neonates. How effective and safe is the sweet solution? A literature review. So this is a literature review based on 10 articles, and its purpose is to evaluate safety and effectiveness of oral sucrose analgesia for infants. It did find that repeated and prolonged pain altered neurodevelopment and socio-emotional functioning. However, it also found that infants who received greater than 10 doses of oral sucrose in their first week of life had poorer neurodevelopment. So it was a kind of, which one do you choose? Do you choose pain or do you choose oral sucrose? And this was a difficult thing for many nurses. One of the things that this study did find that was pretty significant was when measured on the NIPS scale, which is the Neonatal Infant Pain Scale, which measures consolability, facial expression, posturing of the infant, it noticed that oral sucrose does decrease crying, which is part of the NIPS pain scale as a pain indicator, but there was no change in subscales such as heart rate and oxygen, meaning that the physiologic aspects of pain were unchanged by the oral sucrose. And I have in the notes section just to point out that sucrose is considered a non-pharmacological intervention, and I think that's one of the reasons that there may not be a set protocol that we were able to locate on how much you should give, because it's not considered a drug, even though it may have adverse effects. This study was done on neonates, and just to remind you, neonates is defined as from birth to the 28th day of life. Because this was a literature review, there wasn't a specified sample number, only that there were 10 articles included. In my next article I found, which is Sucrose for Procedural Pain Management, this was completed, this was an animal and human study. It did not define human study, only that it was completed on humans. It does mention that there were some less than 31 weeks, but it doesn't say the upper limit or the lower limit of that. And the purpose was to examine evidence about what is known of the mechanism of sucrose for pain relief, as well as the gaps in knowledge to direct further research. So these researchers had also pointed to there needs to be more research done. And it found that sucrose, when used repeatedly, is less effective. So again, there should be a way that we know to only give so much so that it continues to remain effective as a non-pharmacological intervention. They also found that infants less than 31 weeks receiving greater than 10 doses of sucrose had poorer neurodevelopment, just like our previous study had found. This is important because even though 10 may seem like a lot, it's really not. Think of a neonate in an ICU. If that is one lab draw per day, you only need 3 other simple interventions to need to give this patient oral sucrose. So we need to make sure that we're giving them a proper amount in each instance. This study also kind of randomly mentioned that extended and repeated use of sucrose in preterm and sick infants resulted in diabetes. That was just a portion of the literature review that it found. It didn't really give any further information about that. And so when I went to look through the references listed for this literature review, I found that that article that stated that was out of date for the relevancy that we would like in our presentation, but was definitely an interesting article and something that should most likely be studied again. This article also pointed out that a big problem in the research with oral sucrose is people use the words calm and analgesia interchangeably, and they are defined very differently, which is kind of how we started our project to begin with, is does oral sucrose calm the patient, or does oral sucrose actually decrease the pain of the patient, which have 2 very different physiological effects. And my final article was Sucrose-Induced Analgesia During Early Life Modulates Adulthood Learning and Memory Formation. This was a study done at the Jordan University Science and Technology, and it was completed on rats. They were administered oral sucrose and put through different water mazes at specified intervals of time to see how oral sucrose affected short-term and long-term memory. It found that pain during early life causes alteration in pain and sensitivity and cognitive and emotional functioning, which is what our other studies had found. And it also shows that, it also evaluated the fact that analgesia is used less than 10% of the time for invasive procedures. This means that for neonates, we truly need to be doing something to reduce the pain, especially considering the effects that it can have later in life.
So this article was entitled The Effectiveness of Oral Sucrose for Pain Management in Infants During Immunizations. I really liked this article because it was a 3x3 study, meaning that they had 3 different variables, one being 50% sucrose solution, 2 milliliters, another being 75% sucrose solution, and then 2 milliliters of sterile water. They looked at, it was a double-blind and randomized assignment study, and they looked at infants from 2 months of age, 4 months of age, and 6 months of age. And their tool of measurement was the FLACS scale, which stands for Faces, Legs, Activity, Crying, and Consolability. They measured the effects of all of the different solutions that they administered at set intervals. And not only the administrator was blind to it, but also the researchers and the data collectors were also blind to which solution the infant received. So that was very interesting. Their sample size was 113 infants. And the thing that was interesting once I got into it is that they found no significant difference anywhere in means between the groups and between the solutions that were administered. So it kind of made me wonder whether or not the effects of sucrose diminish or go away over time as infants age. The other thing that I found once I started really digging into this study is that there was a huge confounding factor. And that factor was that some of these infants were administered acetaminophen before the immunizations, and they were not, they were also included in the study. I think if I were doing the study, I would go ahead and eliminate that portion of the sample because of that confound. My second study that I found was entitled The Effects of Combined Use of Non-Nutritive Sucking, Oral Sucrose, and Facilitated Tucking on Infant Behavioral States Across Heel Stick Procedures, and it was a prospective randomized controlled trial. What I liked about this study is that not only did it address the issue of pain from a physiological perspective, but it also looked at effects on sleep. The population were infants in a NICU. The sample size was 110, and they looked at augmenting the oral sucrose administration with either non-nutritive sucking, facilitated tucking during heel sticks. They measured the response at baseline, during the intervention, during the heel stick, and at recovery. What they found was, through this study, is they found the combination of oral sucrose along with facilitated tucking was most effective in reducing pain scores during the heel stick procedure.
Okay, so my first article, titled Hospitalized Infants Who Hurt, a Sweet Solution with Oral Sucrose, is a case report involving infants in pediatric and cardiac intensive care units. Babies in the NICU are exposed to approximately 16 painful procedures per day, which leads to the production of free radicals that can cause brain damage. Opioid analgesics are not indicated for babies, and usually no form of pain relief is given. Sucrose is believed to have an endogenous release of opioid effects, and this report concluded that sucrose is a safe, inexpensive method of treating pain management. However, infants given sucrose scored lower on the neurobehavioral assessment scale. This is similar to what Shelby mentioned in her first and last articles discussing the effects of sucrose on brain development in infants. More research is needed in order to investigate the effect of sucrose on neurological development. The second article I selected is Oral Sucrose and Facilitated Tucking for Repeated Pain Relief in Preterms, a randomized controlled trial. It compared the effectiveness of oral sucrose, facilitated tucking, and a combination of both of these interventions between 24 and 32 weeks of gestation. It consisted of a randomized controlled trial in 3 NICUs with 71 infants. The Flack scale was used to measure the pain of the infants before, during, and after the heel stick. This study also concluded that sucrose is effective in managing pain of newborns.
The final article we chose for our findings table was by Sally Wilson and team. This article we actually went into depth. We chose this particular article to do the final appraisal on because it was a quality article, highly credible, and a randomized controlled trial. So the name of the article is The Use of Oral Sucrose for Procedural Pain Relief in Infants Up to 6 months of age, randomized controlled trial. There the citation is listed. This appraisal with Sally Wilson and her team, who they work at a nursing research department at a children's hospital in Perth, Western Australia. And they wanted to take a look at the effectiveness of using oral sucrose to reduce the pain in infants who were undergoing painful procedures. The study was randomized. It was a controlled trial. The sample was obtained using convenient sampling. The researchers worked at this hospital. They had accessibility to the infants that are going to receive these procedures, which it did make it easy and more convenient. Also, it was inexpensive because they didn't have to branch out to locate infants at other locations. The inclusion and exclusion criteria was very specific. Included the infants had to be 1 month to 6 months of age. They had to be undergoing a procedure such as a Hill Lance, where blood was taken for various labs, or a venous vein puncture for IV access. The procedure had to be defined as painful. They also had to have consent. The parents had to consent to the infant participating, and as well they had to be available, obviously, for the consent. The inclusion criteria was pretty vast because they wanted to eliminate any extraneous variables in the study. Obviously, the consent had to be received from the parent. They had to be willing. Also, the infants could not be NPO. They had to have the ability to intake liquids via their mouth. They could not be receiving IV pain medication. Obviously, if they were already getting some sort of pain med, that they may already have some relief there, and that's swaying the results of the study. They couldn't be sedated in any kind of way. That obviously would alter their gag reflex and create another host of issues. Also, if they had some sort of known fructose or sucrose intolerance, they could not participate in the study for those reasons. 90 participants were selected out of the convenient sampling. There were 5 dropouts. 3 of which were due to the researcher not being available at the time the child was going to receive their painful procedure, and then 2 actually vomited at the time that they received the sucrose, which made them ineligible to continue with the study. Now, the data collected was done so using CHIPS. CHIPS is the Children and Infants Postoperative Pain Scale. CHIPS is used not only here in the United States, but around the world. It's been compared to a lot of other methods to record pain in infants, and is deemed to be a very reliable method of collecting this information. The CHIPS scale operates on a 0 to 10 pain scale, and obviously because the infant can't communicate their pain, it gives points based on behavior indicators such as the infant crying, groaning, maybe the infant is guarding, or posture changes, indicating there may be some distress there. Points are given for each of these, and then they're counted and tabulated. The study did have a clear defined intervention. 2 milliliters of 25% was the concentration of sucrose provided 2 minutes prior to the infant receiving the painful procedure. The control group was sterile water was used. 2 milliliters of sterile water was given 2 minutes prior to the procedure. The main finding of this study concluded that when you compare the mean scores, the children that received the sucrose prior did have less pain, according to the scores using CHIP, rather than the infants who had received the sterile water. There was a slight difference, but that there was lower pain scores for the sucrose group. They did use a t-test as the form to measure any kind of significance statistically wise, and the p-value was set at 0.05, and the p-value, according to the mean scores, did not reflect that there was a significant difference. However, there was a difference in the mean scores. It could not be deemed that it was actually statistically significant in this particular study. The study did have indicators of high credibility. For one, it was peer-reviewed. The design was adequate for the type of study. The CHIP scale has been deemed a valuable and very credible method of recording pain. The researchers really did do their due diligence and tried very hard to remove any bias. They used double blinding. The nurses performing the procedures, the researchers had no idea which infant was receiving sucrose, which one was receiving water. They tried very hard with the inclusion and exclusion criteria to eliminate any extraneous variables there. The intervention obviously was well defined with the sucrose. There were some limitations to the study. For one, the sample size. 90 participants were selected, 85 were used due to the 5 dropouts. Could have been larger. That might would have helped there be a difference statistically with the p-value had the sample size been larger. Also, the same concentration, 25%, and amount, 2 milliliters, was provided to all the infants. This was done despite the weight of the infant, so it's unknown if the infant who weighed more, if they had gotten more sucrose, would their pain scales have been different, or if an infant weighing less, if they had received a certain amount of sucrose, would that have changed the pain scale? So those were some limitations to the study. We found, though, that this article and the study was particularly clinically significant and very applicable to our practice. Although the data really didn't support it substantially, the mean scores did indicate less pain for the infants. And for nursing students who go into clinical practice and see in NICUs and nurseries, see the sucrose being used on babies and in infants, it applies to us. We want the infant to experience the least amount of pain as possible when they're undergoing these procedures. Also, it applies completely to nurses and physicians working in the environments on a daily basis to make sure the infant is in as little distress as possible. So we found it to be very clinically significant as well applicable to our practice.
So to synthesize what we found in this journey, or on this journey, we take a look back at our PICO question that we came up with, and that was in hospitalized infants experiencing pain, does 24% oral sucrose solution compared to other comfort measures reduce pain response during a painful procedure? And overall, generally, we found that oral sucrose does significantly reduce a pain response during painful procedures in neonates. We also found that oral sucrose can also be combined with other non-pharmacological methods, such as non-nutritive sucking and facilitated tucking, with significant benefits in pain reduction and shorter cry times. And we did find that the benefit of oral sucrose may diminish over time or have an inverse effect with increasing age in children and infants. We did not find that there doesn't appear to be established limits to the dosage frequency.
Okay, so for our evidence-based project proposal, we designed a project that includes a randomized controlled trial where we would use power analysis in order to determine the sample size needed, and it will consist of infants who are experiencing a painful procedure such as a heel stick. After the parents' consent, the infants will be randomly assigned to two groups. Group A will be given 24% oral sucrose. Group B can be either consoled using methods such as facilitated tucking, a parent's voice, a pacifier, or a placebo. But for the purpose of this project, Group B will be comforted through facilitated tucking. We will assess pain responses before, during, and after the procedures using the Flack scale in order to determine the effectiveness of the 24% oral sucrose. The p-value set in order to determine statistical significance is 0.05. We would also like to continue this project through a longitudinal study following our patients in order to assess the long-term effects mentioned in other studies, such as the development of diabetes or decrease in neurological functioning. This would also be helpful in order to see if there is a decrease in effect of the sucrose over time. So in order to get this information to staff nurses on the unit, we could either hang it on a bulletin board in the staff break room, but for this project, we will hang it in the hallway for staff, families, and the patients to see. There isn't one specific research project that this evidence-based project could inform, but there are several trials out there, such as oral sucrose and facilitated tucking for repeated pain relief in preterms, a randomized controlled trial. And there's another article mentioned titled The Effects of Combined Use of Non-Nutritive Sucking, Oral Sucrose, and Facilitated Tucking on Infant Behavioral States Across Heel Stick Procedures, a prospective randomized controlled trial.
So what we found out of our research project was that oral sucrose, by many different studies, including one we did the appraisal one, does have a difference in the pain levels of infants receiving the liquid when they're having painful procedures. Additional studies could be valuable in determining the statistical significance of oral sucrose and to see if other methods may actually produce better outcomes. Larger sample sizes could be beneficial, as well as different sucrose concentrations or different or alternate comfort measures to see if they may produce the better outcome for the infant. Additional studies could be beneficial in determining the long-term effects of oral sucrose. Currently, we're just not sure what the long-term effects of this usage is, so we suggest going forward we do some longitudinal study following infants through a span for common problems and disease processes determining the long-term effects.
So that concludes our presentation. Thanks for watching.
Thank you.